Today's speakers have no financial disclosures. Our first speaker is Dr. Sean Bryant. Dr. Bryant is Associate Professor of Department of Emergency Medicine at Cook County Hospital. He is also the Assistant Fellowship Director of the Toxicon Consortium. Dr. Bryant is also the Associate Medical Director of the Illinois Poison Center. And with my pleasure, Dr. Bryant.
All right, I'm really honored to be here and speak today. Are we getting a lot of feedback? Do you guys hear a lot of echo? I guess it's just up here. That's okay. But no, I'm really privileged to be asked to speak. I want to thank the organizers for putting this together. And I first want to ask just who here in the room works in a poison center, gathering calls, documenting, and so forth. Could you raise your hands for me? Good, perfect. It's exactly the audience I wanted to hit, and I really appreciate you being here. And I really would like to talk to you, just like I would be talking to my staff in Illinois about these topics. So I'm glad you're here, and I again, am really privileged to be able to speak. So this is where I work. Our poison center is not located here, however. Our poison center is downtown, a little bit east of here. But this is where I do my business in the emergency department, and we see a lot of interesting patients at the bedside. And I think that's the pitfall of not having our poison center where I work clinically. This is a guy, you can see there's lots of issues going on. I mean, I see a swollen right extremity, but look at those wristbands. I mean, this guy's been shopping around, going to several hospitals. We're located in a really interesting location. There's lots of hospitals around us. So quite possibly, this guy's on a lot of medications, could be a toxicologic dilemma, whether it's drug-drug interactions or EKG abnormalities that we'll talk about in a little while. Oftentimes, I ask my residents, my students, fellows, what are they taking? They bring me a list. Sometimes they bring the pill bottle. One thing we always want to do is look inside that pill bottle. So if you're getting a call and they say, oh, they're on X, but that scenario is not adding up to X, have them look in the pill bottle. Here's a great example of a patient who said, yeah, I'm on a bunch of medicines. They give us one pill bottle, and you look inside, and I take a pink one in the morning and a red one in the afternoon, a white one at night, and maybe a purple and black one when I need to. So that's always important. Now, believe it or not, this was one of my previous residents. His name is Jimson, as in Jimson Weed. That's his first name. I love that name. We tried so hard to keep Jimson and do our fellowship. He said, no, I'm moving on. I'm going to make money. But again, patients are bringing these pills in baggies. There's a big baggie of pills. Here's Jeremy, one of our residents, with a big handful of herbal supplements. Again, could have EKG abnormalities associated with it. Sean Reed, one of my favorite pictures here, just left our resuscitation area right in the background with a box of medications that a guy said that he takes. So again, cardiovascular poisoning is very important. It's also something that kind of increases our pucker value. We get worried when there's cardiovascular issues. So I'm certain that something in here is going to mess with this guy's heart or interval changes on the EKG. And we wouldn't call this a box of meds. This is obviously a box of tox, right? So again, where I'm located is quite distant from the poison center. And I hate that because I can't go and grab the spy and say, hey, remember that guy we recommended lavage on? Let's go watch so you can see what that's like. Or that patient who's down there with this particular toxidrome, we have some distance between us. So that's another reason why I think this talk is important. The Poison Center is right downtown, right by the Sears Tower, now the Willis Tower, if you're familiar with Chicago, just east of us. And if you went downtown to Union Station, up on the 19th floor, that's where these great people work. And I really respect their work. I respect your work. You have a tough job on the phone. I mean, it's a heroic thing that you do, treating a patient that you can't see. And I think I want to relay to you that it's tough to ask about an EKG when you can't see it. And I think it's even tougher to ask about an EKG when you don't even know what an EKG tracing means. So that's my point today, and that's my message. I want to talk about these issues and first talk about the game plan of intervals. What is important? What are these CUT or QT interval intruders? Now, to do that, obviously, I'm going to have to talk a little bit about the EKG. We all hear about the QRS, very little on that, but I want to talk about the QT, the corrected QT, its prolongation, and spend a little bit of time at the end discussing methadone, which is, I think, something that we all deal with clinically. So we have goals, and to reach those goals is important during this 45-minute discussion. But you know, as I mentioned, I'm intrigued with intervals and EKGs, but I'm also intrigued with this, PMS, all right? And I'm not trying to be a male chauvinist here, but we have to talk about PMS in order to talk about QT interval abnormalities. And you'll understand what I'm talking about in a little bit. So at our hospital, in our Department of Emergency Medicine, we regularly do M&M conferences. This is where a physician with a resident maybe had a bad case or a death or something that went awry, and they have to present that in front of our department, defend it, and someone gets the task of getting up and discussing that case. And I had the, I guess I'll say, quote, privilege, unquote, of doing that not too long ago about a case that I think is very germane to our talk today. And I love football. You know, it's autumn. You know, you smell it in the air. But, you know, being the armchair quarterback, being that Monday morning quarterback is a tough thing when you're critiquing your colleagues and how they managed a case. So let's start our discussion today about a case that I think is interesting. 53-year-old male, and he's presenting with vomiting, diarrhea. He's dizzy. He's also on methadone. His vitals are pretty normal. His belly's very tender, especially in the epigastrium. And his labs were remarkable for a hypokalemic picture. An EKG was ordered. Our resident was worried because of the abdominal pain that was kind of superior, and maybe this guy's at risk for acute coronary syndrome, so let's get an EKG. For his nausea and vomiting, he was given several rounds of ondansetron as well as IV fluids. So an EKG was ordered. You can see the EKG here, and we'll talk about that. And this EKG is pretty normal, except for when you look at his intervals. And that QTC is quite long, okay? He's got a corrected QT of 591. And by the time you leave here, you'll understand kind of what that is and where that comes from. Now, interestingly, during his stay, he was noted, in addition to being hypokalemic, we didn't know his calcium at the time. He ended up being hypocalcemic. And he got some magnesium later, and I'll tell you why, and retrospectively they found out that his mag level was 1.6. And when you look at his old records, which wasn't done in the ED, this guy had a long QT when he presented on this very day. So the patient was given several rounds of ondansetron. Our nurses, which our night nurses are very good, which I trust, and they walked by and took a look at this guy and grabbed the doc and said, man, this guy's not looking too good. And she looked up on the monitor, and he had a tracing kind of like this. And this is that tracing that you say, ouch, or yikes, you know, what in the heck's going on? This guy was rushed to our resuscitation bay. And you want to know, did I do something to cause this? Was this inevitable in this guy's presentation that very night? He was resuscitated quite well. This is his note. And I only put this up here because when I read a lot of Poison Center charts, sometimes I'll see some commentary in there, and it makes me laugh, I'll be honest. But really, commentary has no place in our charting. And I loved this note by actually my chairman. I mean, it's just what happened. And I think I would submit to you that's really important when you're dealing with somebody on the phone and you're taking notes and you're documenting. Just document what the case is without added commentary. And that's exactly what happened here. So the question is, and I used to love this show. Who liked this show when it was on? Come on, somebody's got to like it. Don't leave me alone. I love this show, and I loved Urkel, and I just loved when he'd say, did I do that? I mean, that's what I would think when this guy's got this new tracing in our emergency department. So this is the uh-oh factor. So let's talk a little bit about EKGs before we get to the meat of the talk, the QTC, and specifically methadone. So here's a normal 12-lead EKG, okay? William Einthoven back in the 20s won the Nobel Prize for giving us this diagnostic tool. We use it quite often. You guys already know that. This is a normal tracing with our different waves. And, you know, I don't want to insult anyone's intelligence, but I think, again, I want to talk about this before we get into the abnormalities. You know, our P wave, our QRS, our T wave, let's talk about this and what these actually mean, and then emphasize the QT. And when you talk about this, you have to realize that there's a lot of ion flux that's causing these waves to look the way they look, causing these segments and intervals to look the way they look, on our EKG, and it has to do with calcium flow and sodium, potassium, and chloride, all right? And this EKG is going to be given to us after we put leads on a person's body and detect what kind of electron flow, what kind of electricity flow is occurring. And depending on where that lead is, the positive lead, if that electricity is flowing toward that lead, we'll see a positive deflection on the EKG. And normally you'll see the flow of electron or the flow of electricity going from the upper right down to the lower left. That's why with our certain leads that are in that area, we'll see a positive deflection. And again, here's several of the leads, where they're positive, where they're negative. If I have electricity flowing this way, I would think that lead 2 is going to be positive. I would think that lead 3 might be a little positive. Lead 1, certainly, which is positive over here, I'm going to see a positive deflection in those leads. Whereas other ones, because I'm flowing towards a negative sensor, I'm going to have a negative deflection. And here's all of the leads here, except for the V leads that I'll talk about next. This gives us the nice coronal view of what's happening with the electricity flow in the heart. And this gives us more of a cross-sectional view. So we'll put leads on the front of the patient, on the back, and kind of take a cross-sectional view of the electrical flow and how well it's flowing. And this will give us, again, a three-dimensional picture of what's happening at the myocardium. So let's make some waves here. Let's first talk about the P wave. Now, the P wave is representing atrial depolarization. Okay, this is initiated by the sinus node. You get calcium influx through T channels, and then it flows through the right atrium. You get a contraction across your interatrial septum through some specialized conducting tissue. You go in the left atrium, and then it gets conducted to the AV node, which sometimes we can have some blocks, and then onto the ventricles to cause the ventricles to contract, and we get blood out. This is all ongoing without us thinking about it. And if we have a beta blocker, calcium channel blocker, we can depress this automaticity and get sinus arrest. So let's talk about the PR interval. This is the interval between atrial depolarization and that ventricular depolarization. It's going to be primarily due to that AV node. And again, if I have a calcium channel blocker or a beta blocker, meds that increase vagal tone, I may have a block, digoxin. And if I have a PR interval greater than 200, we'll say we have a block. And I'm not going to go into the different types of blocks. I think for now, I just want you to kind of understand where we're going here. Now, this is the action potential of the myocyte. And we have different phases of this action potential, and we're going to hit this rather briefly. So I got this phase 0, where sodium channels flowing in, and then phase 1, where we have a little repolarization occurring, and then we have a plateau phase at phase 2 that has to do with calcium and potassium flux, no net flux, if you will. And then we get to phase 3, where potassium flows out of the cell, that ends up repolarizing our cell. So let's talk about the QRS, which you know a lot about. We all know about tricyclics and their effects on QRS. This represents ventricular depolarization. And the length or width of this QRS is a reflection of how well we're depolarizing. So if someone's medically ill and has a bundle branch block, I can't get that electricity to my ventricles in an amount of time that it takes in a normal individual, so I get a bundle branch, or I get a widened QRS, and we call it either a left or right bundle branch block. In the poisoning patient, if I have something blocking this, then I'm going to have a widened QRS, and the typical example is Elavil or amitriptyline or one of these TCAs that is doing this. So we have sodium extracellularly flowing intracellularly into the cell, depolarizing the cell. Remember, the resting potential is quite negative. And if I have positive ions flowing in, I depolarize, okay? And that's where I'll see this deflection on my